Are we ready to go? No? You are live. All right. Good evening, everyone. Welcome to our Johns Hopkins HEAT Corps Town Hall on COVID, RSV, and flu, what you need to know. So the last few years, we have been focused so much on getting to the other side of this pandemic. And I just want to say that we have weathered this with great aplomb. But now we're hearing that we're not quite through the other side of the pandemic because we are hearing that there's a triple-demic. So tonight we have brought with us some experts on this topic so that we can find out exactly what we need to know, particularly as it concerns our school-aged youth. So with us this evening, we have our fabulous Dr. Panagis Galiatsatos, who is a member of the Johns Hopkins HEAT team. Dr. Galiatsatos is an assistant professor at Johns Hopkins School of Medicine in the Division of Pulmonary and Critical Care Medicine. He is co-chair of the Johns Hopkins Health Equity Steering Committee, and he is also the co-director and co-founder of Medicine for the Greater Good, a novel medical initiative impacting over 10,000 Baltimore City lives in regards to health and wellness, while at the same time creating physician citizens. His clinical responsibilities center on critical care services in adult populations, director of the Tobacco Treatment Clinic at the Johns Hopkins School of Medicine, and he is also the associate director of the Hereditary Hemorrhagic Telangiectasia Center of Clinical Excellence, got it, and physician in the Obstructive Lung Disease Group at Johns Hopkins Medicine, as well as in the post-COVID-19 acute clinic. Welcome, Dr. Galiatsatos. We also have with us this evening, Dr. Alba Azola. Dr. Azola is a rehabilitation physician helping patients restore function and movement after an injury or illness. Her expertise includes neurorehabilitation, post-COVID rehabilitation, management of autonomic dysfunction, and rehabilitation for swallowing disorders. Dr. Azola completed her residency in physical medicine and rehabilitation at the Johns Hopkins Department of Physical Medicine and Rehabilitation, where in her final year, she was awarded the Frank L. Colson Jr. Award for Clinical Excellence. And more importantly, she's a mom of two, and she is the co-director of the Long COVID Clinic, where she deals with issues in long COVID such as fatigue and musculoskeletal issues. So we are very excited to be here with both of these experts this evening. As a reminder, my name is Annette Campbell-Anderson, and I am the Deputy Director of the Johns Hopkins Center for Safe and Healthy Schools, and I'm excited and delighted to be your moderator this evening. If you're here watching on Facebook, or if you're watching this through our link, we would encourage you to ask any questions that you have through our chat. So please feel free to drop any questions that you have this evening into our chat, and our HEAT team will be moderating the discussion to make sure that all of our questions get answered. And so with that, we're going to take it away. And Dr. Galiatsatos, I want to start with you and just kind of get a sense from you about where we are in this stage of the COVID-19 pandemic, because COVID-19 was for that starting in 2019, and here we are in 2023. So where are we with this?
Yeah, no, thank you so much, Dr. Anderson. And, one thing I always like to emphasize about the pandemic and why it really got our attention, is because this virus really had this kind of Goldilocks nature to it, right? It was the right way to spread around the world, right? Respiratory, meaning I breathe it in, you breathe it out, it's going around. If this was a GI bug, no, it would not reach pandemic-like levels. This took advantage of social behaviors of human beings where we talk to one another, we're close, we're in shared spaces with sometimes poor ventilation. And then this is it, right? It was the right number for how many patients got sick. What I mean by that was it was enough patients that would develop severe COVID that would overwhelm a traditional healthcare system, right? Our hospitals are not designed to take in every single patient in that area all at once, right? If anything, we're designed to help out maybe 1 or 2% of the population at that time. So really the initial part of the pandemic that caught our attention was severe COVID, and we wanted to combat that. And I would say, as a critical care doctor, we are winning that war, right? We are seeing severe COVID numbers really drastically fall. And a lot of it has to do with antibodies, having our immune system be aware of this virus now, either through prior infections or hopefully through the vaccines, because they're safer rather than rolling the dice with a COVID infection, as Dr. Azola will discuss later, or a little bit of combination of the two, right? With now our immune system aware of this, we end the evolution of this virus with all its mutations. It's really become a really contagious bug, but not one that's life-threatening. So where we're at with the pandemic, it is still prevalent, it is still around, it is mutated even more to being more contagious, evading the immune system, where even if you have some antibodies, they're not going to help you keep it from infecting you, they'll help you from developing severe COVID. So right now, I would say where we're at in the pandemic is kind of where we're hoping to somewhat be, where it's not so much an inpatient issue, it's more of an outpatient issue, where a lot of patients are going to be struggling with what they will tell you is the world's worst cold by catching COVID. So that's where we're at, and we're hoping over the next 6 to 12 months, we'll see the numbers of it become potentially more seasonal, and from that standpoint, really parallel something we've known, such as the flu. So we're not out of the woods yet. We can see the horizon though, but keep in mind, we do have a strong victory over severe COVID that really should be emphasized there. So thank you, Dr. Anderson.
Thank you, Dr. Galiatsatos. And so, Dr. Azola, does this mean that our long COVID numbers are suddenly dropping if Dr. Galiatsatos is saying we're in this new phase?
Yeah, so there's certainly some truth, but there's different populations within the long COVID group, right? And Dr. Galiatsatos sees the acute COVID patients mostly. There is a particular group of post or long COVID patients that didn't have severe COVID, and symptoms were mild at the initial infection, sometimes even not that symptomatic at all. But within 4 or 6 weeks, they start developing new symptoms. And the symptoms can be quite debilitating and can impair their day-to-day activities, their ability to work, their ability to take care of their children. For children, it can cause issues with, maintaining attendance on school. So a lot of fatigue in this patient population that can be debilitating. So that patient population has not seen the drastic drop that we're seeing with the acutely severely ill patients.
So how?
Yeah, go ahead.
Well, no, I'm sorry. I didn't mean to cut you off. I just wanted to follow up on a great point that you made. So how would a parent know, because COVID has just been so ubiquitous in schools at this point, how would a parent know that their child has long COVID over something else? How would they know that?
Yeah, it's actually very difficult for a parent to pick up, but there are subtle things that parents can certainly observe in their child's behavior. A lot of pediatric patients will complain of feeling exhausted. Perhaps they did activities that were normal for them, but then the next day they can feel completely tired and not be able to get out of bed. And sometimes we say, oh, that's just laziness, right? But there's a pattern and a consistent of symptoms that it's persistent, right? Like that's what we want to look for. The other symptom that parents can look for is difficulty with tolerating standing position. Patients that stand and feel palpitations. This is very common on the teenager population, presenting with what we know as postural orthostatic tachycardia syndrome, in where the patient will feel dizzy, lightheaded, sweaty, flush the face, and have a lot of symptoms, nausea when standing up. They can also have issues with ability to eat and maintain nutrition. So sometimes we see in this patient's weight loss.
Okay.
So there's certain chronicity to the symptoms that parents can be looking out for. This is not just, couldn't get out of bed one day. This is something that is consistently happening. And typically we like to say more than 3 months in length.
Great. So who makes the diagnosis around long COVID? Do parents have to take their child specifically to a post-acute care clinic like yours, or do they go to their primary care pediatrician to find out about long COVID? Who's making those diagnoses? So that's my one question for you. And then my question for Dr. Galiatsatos is, and how many cases relative to the rest of the general COVID, long COVID population, what percentage would you say are young teenagers or children? So I'm going to go to Dr. Azola first, and then I'm going to come back to you, Dr. Galiatsatos.
So thank you so much for asking that question. And this has been something that I feel very passionate about, and it's educating primary care. Primary care, it's the front line of our healthcare system, and they need to be equipped with the knowledge that's evolving, right? And we've published guidance statements for, education of primary care physicians. There's too many people with this symptom. So about 10% in a very modest estimate of patients that have COVID will develop long COVID symptoms. In the US, that's approximately 10 million.
My goodness.
Not enough long COVID clinics.
That many. Oh my goodness. I don't think that I knew that.
Yeah.
Wow.
So it's a very important for, if parents note concerning symptoms, like the ones I was talking about earlier, bring into the attention of the pediatrician. Some pediatricians may be familiar. We're working really hard to get primary care physicians to be familiar with what it is and be able to diagnose it. But if not, you can bring it to the attention of the physician as well, right? He had COVID, and it's been since then that the changes are seen. So that should raise a flag for potential long COVID.
Awesome. Thank you, Dr. Azola. Dr. Galiatsatos, is this a more prevalent situation for children and youth versus adults? Is it proportionate? What are we seeing here in terms of numbers?
Yeah, and I really want to just reaffirm what my colleague, Dr. Azola, said. And,
sure.
I know I kicked it off by discussing the win over severe COVID. Yeah. But its consequences, right? That long COVID clinic, if you listen to patients, their life they may not have lost their life, but they've lost their life, right? They're in a whole new different phase of trying to accommodate themselves. And, while Dr. Azola and others see these patients pretty frequently, I can tell you the few times I've been there to work with them, it is the most humbling thing as a physician. So while one part of the battle has been not the acute COVID in my ICU. I saw those numbers drastically fall. This is a whole new shift, and one that I'm praising Dr. Zola and others for really taking on. And so then, Dr. Anderson, you're asking this great question. What is the percentage? Yeah. And the way I'm going to respond is, it's hard to know, right? There's some studies that are saying 1 out of 4. Some studies are about 50%. What I've really taken a step back about this disease of long COVID, we really don't have a test for it. Oftentimes we diagnose it by really kind of excluding a variety of other things, making sure it's not this or not that, a disease we know that we can treat, for instance. And I say this because one of the most frustrating things for patients with long COVID is they come to Dr. Azola, like, I keep being told my tests are normal. But right, we're testing for very specific diseases. We don't have a long COVID test. We just got to rule other things out. The reason why I bring it up in that context is because what long COVID tends to do is it robs people of who they used to be, right? I had an oncology nurse who can't calculate the medication numbers to make the chemotherapy. That may not seem like a big deal, but cognitively, she can't perform where she used to perform, right? So it's robbed her of her quality of life. I have a teenager who, could easily read a textbook at night, right, and study for a test. Now he's struggling with that, right? And needs time in order to adapt because of the fatigue and the cognitive rehabilitation, meaning they've lost themselves that they built themselves up to. So it may not fall, on that traditional pathological level where we'll identify disease, long COVID is forcing us to really create this precision medicine, knowing that the abnormalities may be very patient specific, right? Not being able to calculate chemotherapy regimens may not sound like a big deal, but suddenly this person can't be who they used to be.
So let me follow up. So Dr. Azola, tell me, and we're getting lots of questions, by the way. So the audience is already dropping so many questions, and we've got so much to do and 45 minutes to get through all of this. So I'm going to try to get to everything. Keep on sending your questions. If you're an audience member, we want to hear from you. Dr. Azola, though, it sounds to me like maybe, it could be tied to some of the mental health issues that we have seen really proliferate coming through this pandemic, right? You talk about people being tired, lethargic, possibly depressed. I mean, this pandemic has really done a number. I've been in conversations today where we talked about that, right? And self-care and how people need to walk through this pandemic and make it through to the other side as a whole being. So how do you know it's long COVID and not just depression or not just some other kind of COVID adjacent or COVID responsible mental health challenge?
So you bring an incredibly important point. Mental health has certainly seen an impact as a society from the pandemic and the subsequent years, and the social isolation, kids out of school, viral, virtual learning. So all of this can certainly contribute to some of the symptoms. And it is important to note that one of the key things that we want to focus on is patients not being able to function like they did before.
Okay.
So this is not somebody who's tired after doing soccer or whatever. This is somebody who was an athlete kid that now has trouble walking down the hall or has shortness of breath going up a flight of steps. So it's more about the disruption in function. When it comes to depression, we see a lot of depression from obviously what's happening in society, but also from the loss of function, right? So it's complex. There's multiple factors. I would say that there's certainly loss of function would be a key thing to look at, something. And then the other portion would be making sure that the depression is it linked to the loss of function, right? And then that group is different. And it's hard to tease out. And, primary care physicians have 15 minutes with a patient. And that is very challenging to be able to tease out such complexity of interacting these issues, right? So it is a challenge. It is a challenge, but there's certainly particular clinical presentations that have a physiologic impact, more than just the depression.
So as we talked before this webinar began, the town hall began, Dr. Azola, you talked about your work with teenagers who are suffering with long COVID. Can you tell me a little bit more about the long-term prognosis for students or young people who are presenting with long COVID at this point? And how is your work trying to intervene to disrupt this persisting for a long time?
Yeah, so we really focus on each patient and what are the most impairing symptoms. So we, for example, in a patient that can present with cognitive issues, having new issues with memory or with sequencing speed, verbal fluency, difficulty finding their words, basically, that's what that means, or not being able to follow a recipe, they have to go back and read it again. So that type of deficiency we see in COVID, and then we refer those patients to cognitive therapy, where they learn skills to compensate for some of those deficits, as well as strengthening. So it's like physical therapy for the brain. So that's like the first line, right? And if that first line doesn't completely kind of get the patient where they need to be in terms of their functionality, at times they need to have further screening, psychometric testing, perhaps pharmacological intervention. So that's just one example. In the teenagers that have this difficulty tolerating standing with the palpitations, and this flushing and feeling like they usually describe it like it's a bear chasing me, but there's nothing there. That sensation, those patients, we have treatment for autonomic dysfunction, and interventions that are non-pharmacologic, like hydration, increased sodium intake, compression, that can be helpful, as well as other medical interventions when needed. So we really see, I have a few of the seniors and like early college students that have had trouble getting through the semester. There were A students that were overachievers, and now they're not able to keep up. I have one that, for example, lost her dance scholarship. So this can be quite impairing, and there's management that needs to be done, and there's some that is not medication, and there's some that's medication, but it's in case by case, depending on what's the primary symptom that's causing the impairment.
My goodness. So we do see that this is impacting our future and our young people's lives. Wow. Well, I want to quickly go to a couple of the questions. We've got several questions already, and I want to go to a couple of these questions before we move on and talk about the triple-demic. So I have a question here. I'll give it to you, Dr. Galiatsatos. With the Biden presidency ending the COVID emergency status on May 11th, does that mean that COVID is officially over? What are the implications for that?
Yeah, no, many of us always kind of said there's three endings to COVID. There's the political ending, the personal ending, and then the natural ending. Nature's pandemic, like I said, is probably still going to be around for another 6 to 12 months. We're getting closer. And for those of us who were like in 2019-20, we're like, expect kind of a 4 to 5 year pandemic. I mean, it's playing out to that timeline. So no, nature's pandemic is still present. The political ending of it is tough. And from my standpoint, I appreciate kind of there's a few months prior to that. So because a lot of states and cities really need to do their best in order to make sure they have resources ready to go. If they suddenly see surges, creeping up and so forth, things that they would have relied on more community intervention, like at-home tests or face masks or making sure that we have access to the vaccines, those need to be still in place. So my big thought of it, at some point, yes, we'd have to understand that those kind of federal requirements will go away at some point in time. I'm glad it's not an abrupt ending and like, hey, we're going to give you some grace period. It's really now up to the states and cities, in addition to us, right, physicians and healthcare systems, to really prepare the community of what to do for any moments where there's a surge again. So my feeling of it is one of expectation. I probably saw this coming. It has to come to an end at some point, but it doesn't mean we shouldn't leave this not prepared. So making sure we learn where we can access testing at home, where we can get the most up-to-date vaccines, where we can get outpatient medications like Paxlovid if we should need it. All of that should be the plans that everyone should be putting forward, recognizing, we're going to lose kind of a good, accessible resources for the federal government, but it just means a lot of that planning that falls on us individually as well as city and state levels. So expected. And now hopefully, especially through this town hall, people are hearing this and saying, yes, I got to prepare now. I gotta prepare.
Thank you, Dr. Galiatsatos. And then Dr. Azola, if someone is immunocompromised, will COVID continue to remain a high priority virus, even if the emergency ends? What happens if the emergency ends for immunocompromised folks?
Yeah, that's a great question. I mean, the immunocompromised patient population is certainly at higher risk. They're just not able to mount the response that protects them from the COVID, even if they've been exposed and had multiple infections. So I think that there's some importance to think about society as a whole, right? The immunocompromised patients are present in all settings, and people don't wear a tag saying I'm immunocompromised. But so those patients have to take prevention with masking, with vaccination. There are certain interventions or medications that can help those that don't mount that response. But as a society, we need to also think about those patients. And just to reiterate what we were talking about, even, we're thinking this is going to become more seasonal, right? Yes. So last winter, we saw a surge in all of 3 viruses that were going around. Yeah. And it's important that we are aware of our civil duty, I think, of wearing a mask, of social distancing, of, testing before visiting an elderly parent or somebody that is immunocompromised. So I think that there's a lot that we can do as a community to protect those that are immunocompromised at schools, within family gatherings even. So I think that's an important point for people to think about.
Thank you. Thank you so much. And then I'll bounce this one back to you, Dr. Galiatsatos. So if COVID does become more seasonal, do we still have to take booster shots?
Yeah, so I believe the way we'll see the vaccine campaigns play out in the future will be ones that will parallel flu in 2 ways. One is the timing of them, because that's the ideal thing. Hopefully this can abide by a calendar where we can prepare ourselves for it. Granted, flu came a little bit earlier than expected this year, but at least it was on our minds when it came up. And 2, the vaccines will likely be more promoted for definitely much more vulnerable populations than the general population, meaning like the flu vaccine, yeah, get it. But you realize it's much more emphasized for, say, healthcare workers, yes, right, to keep us safe, as well as, that 80-year-old grandparent or the 20-year-old immunocompromised individuals, as Dr. Azola was pointing out, these fragile and vulnerable populations. So my suspicion is the vaccines will likely begin to look like that. They'll be promoted for the general population, but they'll be emphasized for those vulnerable populations and those at risk of catching it because of the patients we care for. So that's where I'm suspecting we'll see the COVID vaccine play out. I say all this with an asterisk because that's where I'm hoping Mother Nature's taking this. If we should get a curveball from Mother Nature, we'll be back on with another town hall to update that one, I promise you.
Yes, we love to be responsive. So I look forward to hopefully not having to do that, but we stand ready if we must. Awesome. All right. So I want to move on to this topic of the triple-demic. And I know that, there has been a lot of conversation that last fall, particularly in the weeks preceding Thanksgiving, that we were seeing the throes of a triple-demic. So can you talk a little bit about both Dr. Azola and Dr. Galiatsatos, talk about what that meant and what are the components of the triple-demic, right? And why does it matter that we're now talking, not just, you spoke to both of you spoke to how important it is to be prepared against this triple-demic, but tell me a little bit about why this became such an issue and peaked in this November-December timeframe.
I'll jump in first and then pass it off to Dr. Azola. So, COVID is still there, right? It has yet to kind of form a seasonality, though it's hopefully bending towards that. And, back in the late summer, many of us suspected what we'll see out of COVID isn't one variant or subvariant dominating, but kind of a hodgepodge of subvariances. And that's what we've seen, right? BA4 to BA5 to XBB to XBB 1.5. Oh, we really need a new Greek letter. I get that. So, and that's what we've really seen to some extent. And what's happening with COVID is it keeps becoming more contagious. So still surging those numbers. And at the same time, right, with a lot of COVID restrictions falling from public health demands to private decisions, you suddenly saw flu find it say, hey, I'm here, I haven't left. Now I'm going to start infecting. And this newer flu strain that we had, our Southern Hemisphere friends who went through the flu season first were screaming, this one is a lot more contagious and also has some level of lethality to it. And sure enough, we saw that surge. And in December, for instance, I can tell you, I had more flu cases than COVID cases in my intensive care unit.
Oh, wow.
So, right, the flu season came on, and then RSV. That too has a bit of a seasonality, but keep in mind, it's definitely a pediatric disease to some extent. Every parent has heard that. Dr. Azola and I, both parents of toddlers and so forth, we know we come across it, but it's also one that strikes a lot of my elderly patients, those with COPD and asthma. And really RSV just needs the right social setting. So going back to school is one of those, social gatherings, et cetera. But what we ended up seeing is, kids do get RSV. They just tend to get it around the age of 2 and 3. Well, for many 2 or 3-year-olds, they didn't catch it because they were hanging out at home, right? They weren't put in social settings. So meaning when they went back to school, suddenly you got a surge of RSV cases because it was just kids that should have gotten it too got it now. So all those cases just came together all at once.
So it's kind of interesting though, because I just remember as a mom being really concerned when the pediatrician would talk about being on alert for RSV in my children when they were toddlers. Mm-hmm. But we're talking about this triple-demic of RSV and the flu and COVID happening across populations, right? So what is happening that now we have to be concerned about RSV for older age?
Yeah, and RSV in the older population has always been there. It just doesn't get the attention. I mean, it gets the attention from the medical world. I can tell you Dr. Azola and I pay attention to it. Yeah. It just doesn't get that kind of media spotlight from the rest of the world. And now it is starting to surge in that, especially because there's going to be potential RSV vaccines for the adult population coming out. So it's always been there. Every COPD patient can tell you I have to look out for RSV. And one thing I'm hoping we take away from this, right? Silver linings, right? 2 things. One is to recognize that moving forward, right, those face masks should be thought of as an umbrella. What do I mean by that? If your meteorologist is telling you it's about to rain tomorrow, you're grabbing an umbrella. No one wants to walk out in the rain. If we're sitting here telling you there's about to be a surge, a wave of bad respiratory viruses, and be like, yeah, if I'm going out shopping at Wegmans, I'm throwing on a face mask. If I'm going to the DMV and standing in front of strangers, I'm not going to catch something from them and have them ruin my vacation. I'm wearing a face mask. It's a great tool, one that Dr. Azola and I have been doing for decades since we've been in medicine. So 1, I'm hoping that. And then 2, recognizing that with a lot of these viruses, for the vulnerable populations, let's get them the resources they need, such as vaccines. And we'll tackle, of course, the RSV one, because that's likely to come out in another couple months to years. Mm-hmm. But if there's vaccines, make sure the right populations are getting them so they have the chance to fight them off.
Thank you, Dr. Galiatsatos. Dr. Azola?
I don't have much to add, actually. I think I echo all the points that Panagis hit. I think that, again, the umbrella analogy is perfect. I mean, my kids certainly, and actually in my son's 3rd grade class, there was flu going around in the month of December, and there were 2 students who didn't get it, my son and another girl. And I like to think that it's because they're the ones that were masking at school. But it does make a difference, right? So in those times when the community circulation of this virus is increased, it's just something that needs to become more of a common sense go-to. It's
And is it the case that, RSV probably would have been at these levels or would be at lower levels if, we had not had to wear masks for so long, so people would have developed some sense of immunity against them?
Yeah, so what happens is the RSV is such a common virus, and people may get it, every year, and people may be exposed to it, but they got it last year, so they don't get sick. And by having a whole population that's been not sharing that much and wearing masks and locked up in a house for 2 years, right? Now they don't have that immunity because it's been 2 years since they were exposed to the virus. So it hits really hard. So I think that's kind of the science to it, right? Like you have now more people that don't have the protection, and it spreads through the community faster, right? Because
So if you find yourself exposed to RSV, you find yourself exposed to COVID, you probably find yourself exposed to flu, does that predispose you to be more likely to get long COVID or developing some other adjacent condition because of the triple exposure?
Let me dive in real quick here, then we pass it on to my colleague, because as a lung doctor, I get excited about this because Yeah, the immediate infections will have to be managed, right?
Yes.
Sometimes there's an antiviral you can offer, but otherwise it's, staying well hydrated,
Mhm.
managing your fevers as you see fit. But one thing I try to prepare patients for potentially is respiratory virus will leave some consequences,
Mhm.
right? The post-viral cough can last 3 to 6 months, and it's frustrating, especially RSV's post-viral cough. And if you have some underlying asthma, it's going to be rather frustrating.
Yeah.
So these viruses, you got to think of them like a fire to a house. You can put out that fire, there's going to be some damage done, and it's going to need some time to recover.
Yep.
So I see all this because that, to some extent, is part of the biology of the recovery. Now this is where I'm going to hand my baton over to Dr. Azola. The long COVID and these other infections, that's interesting. Dr. Azola, what have you been seeing in clinic?
Yeah. So in particularly with the patients with chronic fatigue and those with POTS, that autonomic nervous system dysfunction,
Mhm.
those populations are not new. These are
Mhm.
patients that have been present just at smaller numbers.
Mhm.
70% of the patients with these symptoms or with this diagnosis
Mhm.
were triggered or by a viral infection.
Oh, wow.
H1N1,
Wow.
mono is extremely
Oh, yeah.
common.
Yeah.
And when it comes to the chronic fatigue, there's certainly a multiple hit theory. So
Mhm.
a lot of my patients had, actually one today, had mono when she was in 4th grade and could not finish the year.
Oh, wow.
And now, she slowly recovered. She doesn't remember much. The mom was helping kind of bring up some of the history,
Mhm.
but then had COVID and is experiencing those same symptoms that she had that, were persistent for a year. So, and at a more debilitating level. So we definitely, there's certain groups of patients that with multiple hits, reinfections from COVID, infections by other viruses, can see a decline, right?
Yeah.
So it's important to be proactive about preventing reinfections.
And so now that we see that we peaked with this triple-demic in December and now we're in February, should we expect that those numbers will stay low until we go back into cold weather? Is this more of a seasonal situation?
Well, I mean, what they tend to, these viruses, these respiratory viruses, are going to take advantage of two things that tend to happen a lot more in the winter time. Being amongst each other in poor ventilated areas, right? That's what it plagues. I mean, how many times have we heard, how about the ventilation? Keep some windows open, throw some fans on, or events outside are going to be a little bit safer than events indoors. So that's why you're always going to see these numbers kind of surge. It's just because of that proximity we have with one another's. And if there's another silver lining, it's not meant for people here, but to recognize that if we can update a lot of our buildings to have better ventilation, you wouldn't see them become such super spreading places. So, it's one of the few things I tell patients to consider doing, like throw in a ceiling fan, open the windows. These will help the air circulate. So those microbes aren't just hanging out, waiting for you to walk into them like a cobweb. So from my standpoint, we have to recognize that's why we tend to see these peaks. COVID is finding its way, at least looking like it'll become seasonal. I think we just have to see how the summer plays out.
Yeah.
The right hypotheses, Mother Nature will let us know if we're correct or not. Flu and RSV have kind of established themselves as those patterns to some extent and haven't thrown us any new mutations or curveballs to deviate from that. So more to come. But if we're aware of how something, like going back, I'll finish this and pass it off. Like, think of the GI bugs that I said earlier. You're not going to get a pandemic. Like first world nations like the US, we have a great sewage system where you're not going to get a massive outbreak of norovirus and E. coli. We fixed that so people don't have to worry about, is their water going to have some bad contaminant pathogen that's going to make me sick? If we can make those same upgrades for a lot of the buildings, especially the schools,
yes,
you're going to see them not being, they'll get cases, but they're not going to be shutting down the schools because of a bad flu outbreak. So just a silver lining there that could potentially happen.
Thank you, Dr. G. Dr. Azola, so one of the questions from our audience members, and we're still getting lots of really great questions. I want to make sure we get to all of them. One of the questions is long COVID contagious? So we're talking about our young people being in the classrooms, going to college even, and those are contained spaces. Dr. G just talked about the ventilation being a really important facet, and I know we really grappled with that at the beginning of the pandemic in terms of facility upgrades. But is long COVID contagious? And if you know that there are children, and you talked about in your son's class, your son being the only one to not catch the flu. So what about this makes parents nervous is the possibility that it could be, long COVID could be contagious. Is it?
Yeah, so that's a great question. And people that have ongoing symptoms past 3 months from infection are typically not shedding the virus.
Okay.
They have tested negative on nasal swabs. They're not positive for the virus, but the virus had started a process in the body that is persistent. And there's a lot of research ongoing about exactly what that process is. But it's known to the medical community that some disorders can be activated by a virus. And the virus is no longer there, but it triggered this cascade of effect. So basically, long COVID, I would say that they're not contagious, right? We don't think of them as people that are actively shedding virus, but we do. But I want to reiterate, preventing getting infected is going to prevent you from getting long COVID.
Yeah.
So it's important to be conscious about that.
Yeah. Another question from an audience member is whether young adults recover faster from long COVID than older members of our population.
That's a good question.
The audience has amazing questions, and they keep
right. I mean, I have some points to say is, like I said, long COVID is a broad term, right? Not only this post-viral fatigues and autonomic dysfunction, but also, post intensive care, right? So when I think about the two populations, elderly are at higher risk for more severe COVID. And thus they're at risk for long COVID symptoms. But the people with this post-viral fatigues are actually younger in age. So studies show that the risk factors are younger ages. So it's usually between 20 and 40 years of age where the population is that's highest or most affected by it. So working population. And I was looking up the numbers for pediatric populations, and again, the studies are small and the populations that they study kind of affect the prevalence, but there's been anywhere from 6% to 30% of patients. So definitely the pediatric population is also affected, but so it's kind of two groups of patients. For the more older patients, we are more worried about them developing severe acute COVID. But definitely the younger population we're seeing, and this is throughout the world. Most recently, we had a paper from England, and yes, it just confirms again that this is a working age patient issue.
Interesting. So we have a audience member who said, if I got COVID last year, should I still be worried that I could be at risk of developing long COVID now?
I would say in the absence of a reinfection, so saying that the patient didn't have a reinfection, we don't expect them to develop long COVID. Long COVID, it's post-COVID conditions are defined as symptoms that started within 3 months, right, from the acute infection. So there's a certain kind of threshold.
And if I can add to
absolutely jump on in,
because what I love about these questions and what you see, hopefully myself too, and Dr. Azola, is like this pause, because why that's important to recognize, as physicians, we tend to draw information from usually three places, right? What we've learned, what we've researched, and then what we've seen. Long COVID is new. So there's research coming out, but as Dr. Azola said, it's very heterogeneous. It's a lot. It's very diverse. And so when you guys are asking these sincere questions, and that's great, where you're asking, where Dr. Azola and myself and others, where we're going to draw from is a lot of it's from clinical experience. Because while we may read the latest study, we sometimes don't agree with how they did it or how they may have defined it. I mean, it's still a new disease and the definition is still kind of misinterpreted or so variable, which impacts us. Like, so yeah, there's a lot of things that we will give you the confidence based on the clinical experience. Our patients are our ultimate teachers. So these questions, keep them coming because we're learning about this disease in real time. I can't turn to my textbook. Dr. Azola is not opening her textbook for med school and being like, let me read this again, right? We don't have that. So that's why you see these like really humbling pauses because we're like, well, let me tell you what I've seen, right? Dr. Azola, wouldn't you agree?
100%. I mean, we don't get taught long COVID in medical school, or actually any of those post-viral fatigue illnesses are not broadly taught in school. So it's something that we're learning about and expanding the knowledge. But yeah, just to the point of long COVID, kind of when does it start? You know, could it be a year after? There's a typical space. So you get the infection, and then there's like a 4-week window, sometimes in some people 2 months, for the new onset of symptoms to start. Or in some other people, it can be just symptoms during the acute illness that continue. But very, very typical, we see a feeling better, and then new symptoms start.
So are there new vaccine recommendations for teens right now? No, maybe not.
Nothing new per se.
I'm not gonna take that. Yeah, I don't. Not that I know. Not that I know.
No, I think parents want to know. Should they be concerned about how often they're vaccinating their young people based on some of the information that we're giving them tonight? So that's good news. Why don't we shift to talking about the potential vaccine for RSV? So there are several in the works. The one that I've heard so much about is this one from Moderna. Dr. Galiatsatos, can you talk a little bit about this RSV vaccine and what it could mean as a game changer in this as part of this triple-demic issue that we've
of course. So, I mean, the big game changer for it, and where I'm imagining the vaccine trial. So there's a lot of, there's 4 companies, I think, that are running an RSV vaccine trial. And it will likely come out in the adults first, because one thing I want to mention to everyone, right? When we've conduct, especially vaccine and other medication trials, if you guys have picked up the COVID vaccine trials, for instance, you realize we try to recruit about 50,000 people. And why that's important to recognize is because that means if there's going to be something that occurs as a side effect, it's going to hopefully occur in those 50,000 people where we can know the frequency. But in rare side effects, like say 1 in 10 million, well, it's not going to occur in that population. It's going to occur in the real world where we launch it out and then we can pick up that rare event of 1 in 10 million. And we usually like to see that happen in adults first before we get to the kids. So the RSV vaccine, as every parent like Dr. Azola and I are, we want it will likely come out in the adults first and then make its way to the pediatrics. What we're hoping this vaccine does is, unlike your COVID vaccine, where the intention is more of preventing a severe illness, right? I tell people the COVID vaccine is your bike helmet. Bike helmets don't prevent you from falling off the bike, but if you should fall off of it, it won't be that bad. We're hoping the RSV can stop transmission. That's what we're looking to see. We're hoping it's similar to, say, the chickenpox vaccine. If you got it, you're not getting it. So to the parents out there, depending on the company, they are making it from a weakened version of RSV, something we've done with many other vaccines. Some of the other companies are using a protein. And Moderna, you're right, the reason why it's getting so much visibility is because of all the other 3, because it's one of the 4. This one was granted to be fast-tracked because it uses its mRNA technology. So more to come from that. But I would expect, maybe this is ambitious, 2023 to have an RSV vaccine, but more likely present in 2024. And last thing I will say about this, and you may have heard Dr. Azola and I discuss, like, it can be severe. A good portion of patients may end up in the hospital. But for others, especially a lot of the kids, it really is a bad cold. So you may say, well, why is that bad? Let me child have a bad cold. The reason for it, I'm going to put it in the context of the chickenpox vaccine, right? That we've all, how many of us here, not to age ourselves, like we've had the chickenpox, right? It was horrible. It was not great. spent a week at home. But we have to recognize that's a disruptor for especially of our parents, where they may have to take time out for work. So chickenpox actually was economically very costly. So that's why we wanted to really see if we can come up with a good vaccine to keep kids at school and not missing those days. And that's what the intention, I think, with the RSV vaccine is. It will likely save lives, but it will also not disrupt lives, meaning parents will have to miss days of work, finding babysitters. You know how hard it is to find a babysitter if your child's got RSV.
Oh, yes. I know.
So long story short, the vaccine's intention is hopefully to prevent transmission. We're hoping to see it, a version of it from one of the companies come out in 2024, maybe ambitiously the end of 2023. But I promise you, when it drops, we will all be here updating you all, because these trials tend to recruit about 50,000 plus people. So it's a good large sample size. So we'll break it down for you guys.
And are there any potential risks or side effects from the RSV vaccine that we should be aware of?
None that I've seen of, because it's gotten to, some of them have gone through already phase 1 and phase 2. I haven't seen any big side effects other than the common side effects of vaccines. I tell every patient, the vaccine revs up your immune system. So yeah, you're going to probably feel achy. And I remind them, you know what else revs up your immune system? Exercise. How many people after exercise, right? Feel tired, drenched, breathless. You know, Dr. Azola's putting these patients through rehab. They're like hating her at the end with their muscles aching. They're like, come on, right? It revs you up. So that's what I've been seeing in the phase 1 and phase 2 trials. So nothing that's caught my attention that warrants conversation, but more of just common vaccine side effects.
And so, Dr. Azola, do you think that there could be like a long RSV, like there is long COVID?
So that's a very good question. Like I mentioned earlier, we know that some viruses are notorious for triggering this type of long mono or long H1N1. RSV doesn't have we don't have a sense, we don't have numbers, right? I just want to be blunt. But in the clinical arena, we haven't seen RSV be a common trigger for this type of lingering symptoms.
Right.
Definitely, like I said, some of the influenza, and actually during the initial influenza pandemic, there was a lot of description of patients with lingering symptoms like the ones that we're seeing, with cognitive issues, decline in function. So historically, there were documentation of this long influenza people that were experiencing. So I think that it depends on the virus. RSV is not one of the notorious ones, but there are certain viruses like Epstein-Barr virus or mono that is very classically.
If I can jump in, this
Absolutely.
This just goes to what Dr. Azola was saying earlier. We really don't learn much about these post-viral consequences. I'm going to scale it back. We don't learn a lot about post-disease consequences. Luckily, we have a field like PM&R, physical medicine and rehab, that does that and focuses on it. But you know that saying of what doesn't kill you makes you stronger? That's not true. It usually just makes you physiologically much weaker. And there's got to be physicians there to pick up the pieces. So as Dr. Azola was mentioning, like there might be viruses that can cause a phenomenon similar. Oftentimes they just really weaken you physiologically, where you just need functionally a good intervention to help you get back to that baseline, hopefully. But we need to be mindful, like rolling the dice with a lot of these infections isn't just like, oh, just a bad cold. They may wipe you out and you may not feel like you've gotten back to normal again. And that's why I tell people, be cautious still, right? So, we're still not through these surges.
So we've gotten some other questions from the audience. One of them is, are there other variants or other diseases that parents should be concerned about this fall? Like I know rhinovirus is another one that has been pretty active this fall amongst children. What are some other things that parents should be concerned about, other infections like rhinovirus?
I was going to say, I know Dr. Galiatsatos and I have both experienced this on our personal children. And enteroviruses are making a strong impact right now. There's a lot of it going around. So this GI bugs, kind of 24-hour GI virus are pretty predominant right now in the children population.
Mhm.
And this is, if we can use this question to create some advocacy here. So, I get these questions when I jump on like health talks with schools, like, should we be reporting if someone gets COVID? And I tell them, like, yes, because you want these schools to make the proper decisions for infectious control, right? We wouldn't be this sensitive if I said you want to know if there's a norovirus outbreak, right? That GI bug that's predominant on cruises. You're going to be like, yeah, that way we know we need to put more hand sanitizers or do A, B, and C. Every parent, talk to your schools, make sure there's a good policy in place. You don't have to reveal names. You don't have to be like, John Doe over here has gotten into a virus, diarrhea abundant.
Yeah.
No, just call in, let them know what their pediatrician diagnosed you with, so the school can be aware and can take the proper precautions to prevent a super spreading situation. And more importantly, to prevent the vulnerable kids in there from getting sick. Rhinovirus may sound dismissive, like that's just a common cold, but in a child with asthma, that's going to send them to the emergency room.
Absolutely.
So every parent down there, like, talk to your schools. Is there an open dialogue, an open level of communication, and a private one where you can just report if you get these bugs, right? That way the schools can do what they can to protect the kids from catching them and really change the policies to some extent transiently to say, we'll do A, B, and C while there might be a bit of a community surge so our kids aren't catching it within the school.
Absolutely. All right, we're winding down. We have just a few minutes, so I want to give you 1 minute each to respond to a question, the final question of the evening about variants. Should parents be still worried that there are more virulent strains of the variants out there between now and the end of this school year that they should be on the lookout for?
So I'll start this off because Dr. Azola should have the last word, finishing off. She's an amazing colleague. So what I would say to every parent is you're going to hear, and this virus will continue mutating, and that flu mutates too, right? How severe to take the mutations? I would try to find a trusted source that you can turn to. Maybe it's us with our town halls, but because every time you hear like it's a new one, and maybe some virologist dubs the Kraken, and you're like, oh, that sounds serious. Not necessarily. Genetic potential doesn't necessarily always mean it'll play out to clinical potential. So what I would say is, should you be concerned? I would probably rephrase it. Should you be aware? Yeah, maintain some level of awareness. But find those trusted outlets where they can tell you, should you raise your awareness to a concern level or not? Maintaining awareness is fine. Just like I watch the news for weather, I'm aware of it. I'm not concerned unless the weatherman is telling me there's a bad blizzard. So my last weather analogy, over to you, Dr. Azola.
They're being good weather analogies. So I agree. I want to echo, Panagis and a lot of the points. I think that it's important for awareness of this, but it's actually something that's going to continue, right? We know this is what viruses do.
Yes.
They change, and all viruses have this kind of small changes and mutations that create new variants that usually helps them survive more, right? It's just the important thing that I think is parents should get more aware about or concerned about is prevalence in the community.
Okay.
Right. So when the news says that the numbers of positive cases are rising, the number of hospitalizations are rising, those are ones that you don't want to be anxious about, but you want to take those extra precautions.
Absolutely.
The variants, they're going to be there.
Yeah.
But what is affecting your community and what the prevalence is, that's what really can activate some of the common sense, social distancing, masking, all those things that we learned so well in COVID. We can just apply those when those surges in the community happen.
Awesome. Well, I want to thank both you, Dr. Azola, and you, Dr. Galiatsatos, for spending this last hour with us talking about this really important topic. I'm really excited that we've gotten this information out into the community. I'm really glad that the community had an opportunity to ask really important, relevant questions to these experts. So with that said, we're going to wind down our evening together. This is our town hall on COVID-19 and RSV and the flu. And I want to thank you, our audience, for joining. I am Annette Anderson, and I have been your moderator, had the great pleasure of being your moderator this evening. I want to thank you. If you want to see this, this town hall or share it, it will be up on our HEAT website so that you can share it. I want to thank our HEAT team, our fabulous HEAT team that produces these wonderful town halls, for all your hard work. And I want to say good evening to everyone. Thank you. Have a great night.
Thank you for the opportunity.
Thank you. You were
A pleasure.
amazing. You were amazing. I
Anytime, happy to
learned
help.
so much. I can't wait to have you back.